Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering the difference between the non-stress test and the contraction stress test. Before we get started, guys, if you haven't done so already, please like this video. This will really help that algorithm going. So press that like button. You're going to love the video, but press it now so you don't forget. And don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. If you haven't already subscribed to my channel, please do so. All right, guys, so let's get started. We're going to start with the non-stress test. And basically, guys, the point of this non-stress test is to see if the fetus reacts the way that it should. If we're seeing accelerations with, fetal movement or uterine contraction, we just want to see if the fetus is reacting the way that it should. So take a look. It says the non-stress test is the most widely applied technique for antepartum evaluation of the fetus. The basis for the non-stress test is that the normal fetus produces characteristic, that means things that we should be seeing, characteristic heart rate patterns in response to fetal movement, uterine contractions, or stimulation. Let me be clear, guys. You see these three? What should we see happening? We should see accelerations. We should see the heart rate go up. Just like you're outside of the womb. When you start moving, doesn't your heart rate increase? Of course it increases, because when you start moving, your metabolic rate increases, your body needs more oxygen, so your heart responds by increasing, the rate so it can push out more oxygenated blood to the tissues. And that's what we expect to see in the fetus. Let's keep going. In the term fetus, accelerations are associated with movement more than 85% of the time. This is what we expect to see, guys. The most common reason for the absence of fetal heart rate accelerations is the quiet fetal sleep state. However, CNS depressant medications, chronic smoking, and the presence of fetal malformations can also adversely affect the test. So usually, if we're not seeing those accelerations like we should, usually the reason for that is the quiet fetal sleep. But there are things that can cause that fetus not to accelerate as it should. And here's a list that you guys absolutely have to know. Again, smoking, presence of fetal malformations, or if there are depressant drugs in the system, the fetus is not going to react as quickly or as it should. Now take a look at here. This test is non-invasive. That is wonderful, because guys, anything that's invasive, we're increasing the risk of introducing pathogens and organisms into the patient and giving them an infection, right? That increases the risk of infection. So that's wonderful. It's non-invasive. It's easy to perform and interpret. It's inexpensive. And there are no contraindications. That is wonderful for the non-stress test, because the stress test is a different story. But this is important for you to know about the non-stress test. All right, let's talk about the procedure. So the woman seated in a reclining chair or in a semi-phallus position with a slight lateral tilt to optimize the uterine perfusion and prevent supine hypotension. The fetal heart rate, let me stop right there because I got to make sure you guys understand this. So that lateral tilt that they're talking about, guys, of course, when you want to increase perfusion to mom, you place it on what? The left side. Great. But if you get a test question asking you where you're going to place the pillow, do not choose the left side. You want that patient on the left side. So where are you going to place the pillow? You're going to prop that pillow on the right side of their back, so they're leaning more on the left side. Don't get tricked. Okay. All right. Now we can keep going. The fetal heart rate is recorded with a Doppler transducer and guys, I can never pronounce this word. You see it. Tocodynamometer. There we go. Tocodynamometer. It's applied to detect uterine contractions or fetal movements. And again, with those uterine contractions and fetal movements, what do we expect to see? We expect to see accelerations, increase in the heart rate. The tracing is observed for signs of fetal activity. And look at this word. This is a key word. Concurrent accelerations in fetal heart rate. Why do you think the author put this word concurrent? Because they could have just said the tracing is observed for signs and symptoms of fetal activity and acceleration of fetal heart rate, right? But they put this word concurrent here for a reason. Why? We want to see as that fetus is moving or as those contractions are happening, at the same time, we're seeing accelerations, we're seeing increase in the heart rate. Because guess what? If the patient's having contractions or the fetus is moving, but the acceleration is delayed, that's the problem. That's taking a little bit too long for the fetus's brain to tell the heart to start pumping a little bit faster, okay? And that's why you see that word concurrent. When you guys are studying, please, the way I'm teaching you, this is how I want you to think. You have to say to yourself, okay, why did they put that word here? Because they could have just left concurrent out. There's a reason they put in there. We want to see it at the same time. Let's keep going. If evidence of fetal movement is not apparent on the tracing, the woman may be asked to depress a button on a handheld event marker connected to the monitor when she feels fetal movement. Why? When she feels a fetal movement, we're going to look to see if we're seeing accelerations. It makes sense. The movement is then noted on the tracing. Because almost all accelerations are accompanied by fetal movement, the movements need not be recorded for the test to be reactive. Hint, hint, reactive, that's a good thing. That's what we want to see. We want to see accelerations, okay? Non-reactive, that is bad. So let me show this to you. You'll see where I put, well, I didn't put a happy or sad face. I should have, but good, bad. So if you guys have noticed, this handwriting is definitely not mine. I'm teaching out of a book of one of my former students who, she took good notes from my book. So anyway, take a look at this. Reactive test, that is good. Put a happy face next to it so you can remember when it comes to the non-stress test, reactive is what? Good. So what is the reactive result or interpretation? That is having 2 accelerations within a 20-minute period, and each of them lasting at least 15 seconds, and the peak, it peaking at least 15 beats per minute above the normal baseline, going at least 15 beats per minute higher than the normal baseline. That is good. This is what we want to see. Look at the non-reactive. That's bad. Put a sad face next to it so you don't forget. Non-reactive result, this is a test that does not demonstrate at least 2 qualifying accelerations within a 20-minute window. All right, that is your stress test. That is your non-stress test. Let's move on to the stress test. I'm moving a little bit too fast because I have interpretation down here. I'll go over this with you guys, but this is exactly what I just read to you in the box. Again, the non-stress test. The non-stress test results are either reactive or non-reactive. Again, reactive, that's good. That's what we want. Non-reactive is bad. We don't want non-reactive. A reactive non-stress test is considered normal. That's why I told you put the happy face, while a non-reactive stress test requires further evaluation. What's going on? Why aren't we seeing these accelerations like we should with fetal movement or with uterine contractions? If the test does not meet the criteria after 40 minutes, guess what? Then a contraction stress test or a biophysical profile should be performed. Okay, so we remember, guys, in nursing and medicine, we're always going to go from the least invasive to the most invasive. So we love the non-stress test, but if we can't get the reactive result that we need within 40 minutes, we're going to have to go ahead and do that contraction stress test. Okay. Now let's talk about the contraction stress test. Now we're talking about it. So a contraction stress test, also known as the oxytocin challenge test. Remember oxytocin, guys? It helps contract the uterus. The contraction stress test or oxytocin challenge test was the first widely used electronic fetal assessment test. Uterine contractions decrease uterine blood flow and placental perfusion. Every time there's a uterine contraction, less blood flow is going to the fetus, and less perfusion is going to the placenta. Remember, I taught you what that word perfusion means. When you see that word perfusion, that means how much the tissue or organ is actually being fed the oxygen, vitamins, mineral, nutrients that are carried in the blood. So every time there's a contraction, that's decreased. If this decrease is sufficient to produce hypoxia in the fetus, a deceleration in fetal heart rate results. That is bad. Put a sad face next to it. We do not want to see that. We want that when there are contractions, that fetal heart rate is still accelerating, that fetus is not in distress. And the reason we want to see that is when mom really goes into labor, the fetus may not be able to handle those contractions, okay? Look at this nursing alert. In a healthy fetal placental unit, uterine contractions do not usually produce late decelerations. We don't want late decelerations. Whereas if interrupted oxygen is present, contractions produce late deceleration. Okay? So even with those contractions, the fetus should be able to still get enough oxygen. And how's it getting that oxygen? We're seeing that heart rate go up because it's that heart rate that's going up that's pushing out that oxygenated blood, right? So right here, late decelerations, bad, sad face. We do not want to see that at all. Let's keep going. The contraction stress test provides an earlier warning of fetal compromise than the non-stress test, and it produces fewer false positive results. Contraction stress test, it's more time-consuming and expensive than the non-stress test. Also, it's an invasive procedure if oxytocin stimulation is required. In general, the contraction stress test cannot be performed on women who should not give birth vaginally at the time the test is done. This is important. Let's stop here. Give me a second, drink my coffee, and I'll explain to you why. What they're saying to you is that this test, the contraction stress test, should not be done if the woman is not prepared or cannot give birth at this time. Why? Because the contraction stress test can cause a woman to go into labor. So let's say the fetus, the lungs are not mature. There's not enough surfactant yet. That fetus is not going to survive outside the womb. Are you going to do the contraction stress test on this mom? Absolutely not. Because if she accidentally goes into labor from this test, we're in trouble. That's what they're saying to us here. In general, the contraction stress test cannot be performed on women who should not give birth vaginally at the time the test is done. Absolute contraindications for the contraction stress test are the following, and you need to know them, guys. Preterm labor, placenta previa, vasa previa, cervical insufficiency, multiple gestation, previous classic uterine incision for a C-section birth. You need to think about this, guys. The contraction stress test will literally cause the uterus to contract. So if mom has some kind of contraindication where she cannot deliver that fetus vaginally because guess what? The uterus is contracting to push that fetus out, you better not do it on this woman. Make sure you know this list, these contraindications. I promise you, if you're taking OB right now, that's going to be one of your test questions. You have to know the contraindications to the contraction stress test. Okay, because of these disadvantages, the contraction stress test is generally used as a backup rather than a primary method of antepartum testing. Hence why, what do we do first? The non-stress test, and hopefully all goes well. So let's talk about the procedure for the contraction stress test. The woman's placed in semi-phallus position or sits in a reclining chair with a slight lateral tilt to optimize uterine perfusion. And when they talk about the tilt to optimize perfusion, they talk about tilting her to what side? The left side, okay? And avoid supine hypotension. She's monitored electronically with a fetal ultrasound transducer and a uterine tocodynamometer. So, excuse me. The tracing is going to be observed for 10 to 20 minutes for the baseline rate and variability and possible occurrence of spontaneous contractions. Hopefully that happens. If she has spontaneous contractions, we won't have to give her the oxytocin. So that we're going to monitor her at first. Remember, we always want to go, guys, from least invasive to most invasive. The two methods of contraction stress test are nipple stimulation contraction test and the more commonly used oxytocin stimulated contraction test. Why? Stimulating the nipple and getting that exogenous source of oxytocin, both of those do the same thing, which is cause uterine contractions. Okay, so let's talk about the nipple nipple stimulated contraction test. Let's talk about that one first. What do? Massaging the nipple. This causes a release of oxytocin. Remember, it's the oxytocin that causes the uterine contraction. So massaging the nipple causes a release of oxytocin from the posterior pituitary gland. And you guys know that. You guys watched my video I did on all of these glands. In the posterior pituitary, you only have two, oxytocin and antidiuretic hormone. Everything else is in the anterior pituitary. So that's very important for you guys to know. It's important to know that massaging that nipple will cause the release of oxytocin. It's important to know that oxytocin will cause uterine contraction. And it's important to know oxytocin is found where? In the posterior pituitary. Let's keep going. When adequate contractions or hyperstimulation that's defined as uterine contractions that last for more than 90 seconds or 5 or more contractions within a 10-minute time span. When this occurs, stimulation should be stopped. We're not trying to overdo it. So when the woman has adequate contractions or we know hyperstimulation, stop. And they told you what the hyperstimulation is. It's defined as uterine contractions lasting for more than 90 seconds or having 5 or more contractions within 10 minutes. That's enough. Let's talk about the oxytocin stimulated contraction test. Exogenous, that word exogenous means outside. So you can have endogenous oxytocin where your body naturally makes and releases oxytocin, or you can have exogenous where you're getting it from an outside source. It's being injected into you, or you taking it orally, depending on what we're talking about. In this case, it's being injected in. Exogenous oxytocin can be used to stimulate uterine contractions. An IV infusion is begun. The patient will be getting it intravenously. One method of oxytocin infusion is to begin at 0.5 milliunits per unit and double the dose every 20 minutes until 3 uterine contractions of moderate intensity lasting 40 to 60 seconds are observed in a 10-minute period. That's a mouthful, but you have to know it. Don't shoot the messenger. Again, one method of oxytocin infusion is to begin. We're going to give them 0.5 milliunits per minute, and we're going to double that dose every 20 minutes until we get 3 uterine contractions of moderate intensity, lasting between 40 to 60 seconds, all within a 10-minute time span. Okay? Approximate the stress experienced by the fetus during the first stage of labor. This mimics what that fetus is going to be experiencing during that first stage of labor. So we can see, is this fetus going to be able to survive? Is this fetus going to be able to handle these contractions? Is this fetus going to be able to handle the labor process? Interpretation. By the way, guys, everything you see that I highlighted, that I underlined, and especially there's a star next to it, make sure you know it for your test, okay? So let's talk about interpretations. If no late decelerations are observed with the contractions, the findings are considered negative. Repetitive late decelerations render the test results positive. You guys see that? So if we don't see any late decelerations, so the patient's having contractions, but we're not seeing any late decelerations, that test is considered negative. Guess what? That's a good thing. Late decelerations are bad. Repetitive late decelerations render the test positive. That is bad. We do not want late decelerations. Let's keep going. The desired contraction stress test result is negative because it has consistently been associated with good fetal outcomes. When that test is negative, that's letting us know we're not seeing those late decelerations, and it's very likely the fetus is going to be able to survive the labor process. Positive contraction stress test results have been associated with intrauterine fetal death, late fetal heart decelerations in labor, intrauterine growth retardation, and meconium-stained amniotic fluid. Bad. Put a sad face next to that. A positive contraction stress test result usually leads to hospitalization for further close observation or birth. Again, when it comes to the contraction stress test, we want a negative result, not a positive result. Unsatisfactory, suspicious, and equivocal tests require further evaluation. We got to see what's going on. And up here, you'll see this note. Do not confuse acceleration with late deceleration. As students, you guys kind of, I don't know why you guys do that, just mix it together. It's not the same thing. Accelerations are good. We want to see the heart rate go up with any type of stress. Late decelerations are bad. We do not want to see that at all. Now, one last thing I'll cover with you, take a look at this box. Again, I can't stress this enough. When it comes to the contraction stress test, a negative result is good. That's why you see this happy face. What is that negative result? It's a test at least 3 uterine contractions in a 10-minute period with no late or significant variable decelerations. Good. What's bad? A positive result. A positive result shows late decelerations that occur with 50% or more of the contractions. Now, these last 3, it's not a happy, it's not a sad, it's just a straight face. And the reason it's a straight face, it just means we need to do further testing to see what's going on. So you guys can pause to read that on your own, okay? And guys, that is the biggest difference between your non-stress test and your contraction stress test. If you're taking OB or maternity right now, please, you might have to watch this video twice to get what I'm saying, but make sure you watch it. Everything I have a star next to that I underlined, highlighted, make sure you know it. You're going to see this on your test. Let me know in the comment section what you guys thought about this video, what you'd like to see me cover more extensively on the next video. Don't forget, Sundays, 1 p.m. Eastern Standard Time, I have a video that's released where I actually go over nursing questions. I teach you how to figure out what the right answer is. I teach you how to eliminate wrong answer choices. I have audio lessons available on my website, nexusnursinginstitute.com, and almost daily. If you guys would like to practice more nursing questions, you guys can catch me on my other social media platforms such as TikTok, Instagram, and Facebook. Thank you so much for watching this video, and you guys will catch me on the next video.